Good evening to one and all present here. We would like to begin our webinar. The theme for today's webinar is mental health in catastrophes and emergencies. Thank you to one and all who are present here with us today. It would be my honor and privilege to welcome our speakers for this evening, Dr. Alfred Solomon, Mrs. Hindumati B, and Mrs. Anbueshwari K. The key topics for this evening will be mental health strategies for refugees and displaced communities, building resilient mental health systems in crisis zones, and decentralizing mental health support as community led interventions. Kindly note, all participants kindly switch off audio and videos during the webinar. Any questions can be typed in the chat box, and the speakers will be answering them at the end. I now welcome Dr. Alfred Solomon, Assistant Professor at Savita College of Nursing, Chennai. Sir has over 10 years and 8 months of experience in psychiatric nursing and specializes in teaching, clinical instruction, and research focuses on evidence based practices and compassionate patient care. He is also committed to inspiring the next generation of nursing professionals. Sir has completed his BSc Nursing from Garden City College of Nursing, Bangalore. Sir is a certified art therapist, a counselor, and mental health provider from NIMHANS, and a certified psychological first aid at Johns Hopkins. He is also certified as a mindfulness based cognitive behavioral therapy, and Sir has many well known research works, over 15 published in journals such as Scopus and international journals of development research. We welcome you, sir. Over to you.
So before beginning my topic, I welcome everyone for this session. So I wish you a happy mental health day for everybody. And as we the professions, as the nurses, and as well as the mental health professions who are in the forum, I welcome you all once again. So today the topic I'm going to discuss is about the mental health strategies for refugees and displaced community. So here we have three keywords. One is mental health and the strategies for refugees and displaced communities. So the objective of my session is about to share a key facts about global displacement and mental health burden and the show stresses refugees face during migration and settlement. And we are going to discuss something about the therapies and communities and support programs. And I'm going to explain about something WHO strategies and activities for refuge mental health and promote policies that protect the right and improving the inclusion. So I feel privileged to present this topic. This is one of the much needed burden topic, and I'm lucky to present this. So now you can see this slide. There is an Afghan boy's daring flight to Delhi. So this was a recent news, and which we came across, and the entire nation was shaken. Not only the India, and all over the world, the attention towards this boy who flew from Afghanistan to Delhi in a flight on the wheel. That is a landing gearbox. He was hiding and he landed to Delhi. He found to be roaming in the airport of the Delhi, and at last the Indian securities found him. And after the inquiry, they came to know that he is a refugee. He want to go to some other country from Afghanistan, and by mistake he has boarded. He has hidden himself in the landing gear. That is a cabinet of a wheel where the flight is going to be fixed. In that he's hiding, and he was traveling 2 hours of dangerous travel from Afghanistan to Delhi, and it was a hard climate. So later on, that experts say it was a hard travel, and it was the hard climate. However, the God saved him, and he has landed safely to Delhi, the gearbox, not inside the flight. So this was this shaken the world. So almost every nation was shaken by because of this boy. So the reason is the problem. So he tried to go as a refuge to some other country, but he has mistakenly boarded the flight. So this incident itself shows that how much the mental health is essential and needed, what it has the role over the refugees and the displaced communities. So before getting into the topic, I just want to formally define what is refugees and who are the displaced communities. So according to 1951 United Nations Refugees Convention, the refuse are the person who, owing to well-founded fear of being persecuted. I'll explain. I don't want to take much of a time. I can explain the definition. So these all are the peoples who was always having a fear of persecuted. They have the fear they would be killed. found to be fear and to be killed, and for the reason of race, religion, nationality, membership of a particular social group or political opinion outside of the country or the nationality, unwilling to avail themselves for the protection of that country. So this definition says that these people have fear, and they don't have safety and security in their own country because of any war or because of some racialism or some political problem or war or crisis, anything it might be. And they would be seeking help from the other country, and they will be going as a refuge to seek help to other countries. So this is what the 1951 definition of United Nations Refugees Convention states. So next, I want to explain about the displaced communities. So these peoples also called as internally displaced persons. So this definition was given by UN guiding principles of on internal displacement. So here the individual or group who has been forced or obliged to flee or leave their homes or places or habitual residences, in particular as a result or to avoid the effect of armed conflict, generalized violence, human right violation, natural or human made disaster, and who had not crossed an internationally recognized state or border. So these peoples, the major difference between the refugees and displaced community, the main thing is refugees, they seek the help and they will be crossing their border until they will be seeking help to the other country. That means, for example, an Indian going as a refugees to Pakistan, and especially the south part of India, Tamil Nadu has faced this because we get most of the refugees from the Sri Lanka during those war times. We received much of the peoples who affected in the Sri Lankan war. They came as a refugees to the down part of South India. So here the displaced communities are the peoples or individuals who was obliged to flee, leave their homes or place habitual residence in their own country. For example, if you take a place, for example, it happens in the where the Manipur, it has happened in the Manipur. So here the people would have they lose their house and habitual residence because of the internal problem, and they lose their habitual spaces, and they will be staying in the same country. So this is what we call it as internally displaced person. So they don't have safety, they don't have security, they don't have food, they don't have shelter. So this is a condition. It might be a man-made disaster, or it might be a natural disaster, it might be a war, or it might be anything. But these peoples in their own country, they will be as a refugees. This we called as internally displaced person. So this is what a key difference between the refugees and displaced communities. So I hope you would have understood why the mental health has a much burden over these two communities. So now let's discuss about some key facts based on the statistics of 2024. 123.2 million forcibly displaced worldwide. So recently, the world is witnessing about the Gaza and Israel war. So if you want, almost everyone, even people at the down corner of earth knows about the issues happening between the Gaza, what's happening in the Gaza. So 73.5 million internally displaced person and 36.8 million refugees and 8.4 million asylum seekers and 5.9 millions other needing protection. So this is a statistic by WHO, UNHCR 2024. 71% of refugees hosted in low and middle income countries. So you can see Rohingyas, Bangladesh, Indonesia, and Sri Lanka, Gaza. So everywhere we can see many of the refugees. So now, what would be the mental health burden? So I don't want to discuss about the economy or poverty or this all. We don't have much time to discuss. Straight away, I'm getting into the mental health burden. What's the role of nurse and a mental health profession and a mental health governing bodies to handle this problem? So here the mental health burden which has on this particular person is higher risk of depression, anxiety, post-traumatic stress disorder, suicidal behavior, psychosis, and limited access and disrupt of continuity of care. So this is what the mental health burden. It's very common to understand the severity of the problem. As we take ourselves as an example, if I put you or if you put me in a place which is new to me and there's no comfort, and even we face sometimes in Chennai when I used to stay in Chennai, we used to get a severe rainfall. So during those days, we don't have get a proper food and no electricity and no roads to access, and it will be a darkest day of Chennai. So even we cannot. It's very difficult for us to cross those 3 to 4 days because literally it is a difficult situation. Obviously, we don't go for depression, and we'll be having a mild anxiety, and we'll be having a stress. I don't know what is going to happen, and especially we can take the days of tsunami. So how the entire community of the tsunami got affected. So still the follow-up care is going on in the tsunami affected area. That is post-traumatic stress disorders found in tsunami. So these all are the mental health burden. Obviously, if a person doesn't have his house, if the person doesn't have his family, if the person loses habitual place, and the person come out of the comfortable zone, the person doesn't have food, if the person has poverty, hungry, obviously this will indirectly or directly affect the mental health of the person. So how mental health profession is going to handle this? So that is all the session is about. So what are the stresses across migration journey? So here we have four states. So first is pre-migration. So the migration is from the place where the problem that is on curfew or problem or anything is happening. So that's a place from there to the place where he's going to be. That's other nation. So pre-migration. So it is because of conflict, poverty, persecution, or disaster. So these four might be the reason for the person to migrate from one place to another place. So here, this conflict obviously it will give an mental health issues, poverty, persecution, disaster. Obviously, you'll be facing the anxiety and fear. Next, we talk about the transit. So when we talk about the transit, violence, detention, unsafe travel, lack of services. So those giving a sense of greatest insecurity, especially for women's and children's. And it's not something we are discussing in a comfortable room and in a comfortable forum. But crossing a border from country to the country is not that easy task. So he has to face a lot of the main threat of what the person will face is about the fear of life. So anytime anything may happen to the particular person, army of the same country may shut down or army of the opposite nation where is going to be as a refuge, they may be shot down. They might do something to these refugees or something among the peoples, something the natural, sometime the animals. So anything it might be, they have a lot of fear. And with this hunger, all this have an impact over the mental health. So when you talk about the post-migration, poor living conditions, family separation, uncertain legal status. So once they reach, after their condition would be very, very different. They might be left the family members. The family might be scattered, or they don't have. They might lose their loved ones in front of their own eyes. So these all are the conditions which might be a greatest stressors for this people. And when you talk about the integration, unemployment, cultural challenge, racism, exclusion, and deportation risks. So if you be a as a refuge for a new country, it is very hard to live there. The life is not that easy. So you won't get a job. You might not have a proper recognition, and you will be having cultural challenges. The people of those country may not accept you. The racism, they always may treat you as a inferior and exclusion. They may the ethnic or cultural group they won't accept the refugees immediately. So, however, they will be having a bad look over them as a refugees. So these all are the great stressors. It's not only take 1 or 2 days. It won't be solved in a week or month. It may take years and years to accept the refugees. Still, in areas of Tamil Nadu, I can see some Burma colonies. The example. So these Burma colonies still they are using that name. It's been a centuries ago, the peoples from the Burma, they're all Indians, but they had been for some estate work and they came back during the Second World War. And still, people call them as a Burma colony. The reason is they don't have any impact and they're living happily. And it's been they are a fourth or fifth generation. They lost all the impacts about the war and migration or refugees. But still, the word is remains. We call that as a Burma colony. The reason is the impact of refugee is not a one-day journey. It's an years together and generation to generation. So next we see about the prevalence condition. What are the mental health conditions these refugees and the displaced community faces? Depression, anxiety, post-traumatic stress disorder, suicide, fatigue, anger, physical complaints, distress, anxiety, sadness, and insomnia. So these all are the major conditions, psychiatric condition these people face. So collectively, I can tell some signs of all this. They will be having fear. They won't take proper food. They won't sleep
They
proper.
won't sleep proper.
They won't smile with others, and they cannot share their emotional feeling to others. A lot of things, fear especially. So repeated thoughts, repeated fear, low self-esteem, all together contributes many of the mental health issues for these people. So how the entire world is handling this? So refugees is not one or two; it's a million peoples, thousand to millions and millions to crores. They cross the border and they come. How the receiving government is going to take care of them? What is the role of community over here, and what is the role of healthcare peoples here? So that is what. So policy makes here. Here, a single person cannot do anything. If a single person is going and helping for the refugees, the law might discriminate him in a different way. It depends on the country. So the policy of each country who receives the refuge has their own policies and own protocols. So here, the main policy consideration should be a community support and inclusion. So community support and inclusion of the peoples. The peer mentorship, family unity is essential, and social determinants of food, housing, safety, education, job has to be provided to these refugees, and integrating the mental health into general care, that is training the health and social workers, and a flexible service, that is location provider, culturally adapted care. And next is protect of human rights. So this is one of the major complaint. The violation of the human rights is most of the problem in the refugees. So the people, the country who receiving the refugees, those person, those security personnel or police or army or whomever it may be, they take this advantage of the situation. So most of the time, the women were harassed by these security personnel and guards, and sometimes children to be abused. So these all are the potential problem and the actual problem which was faced in the past cases, and strengthen the community capacities, that is outreach, referrals, and continuity. So this is all about the policy consideration. So all this knowledge will help you to understand how the country or a system or a structure is handling the refugees and displaced communities. So now the WHO has given the strategies and approach how to handle these refugees. So here they have given some points over the leadership and advocacy. I have minimized everything because since we have a this is not a guest lecture, and this is just a sensitization mental health talk. Since I cannot go much deep into it, so I'll be giving an overview idea. What's the just a significant feature about this refugees and displaced community, the concept of mental health nursing. So when you talk about the Global Action Plan on Refugees and Migrant Health, 1923, though this is adopted at the 72nd World Health Assembly, aim of this advocacy is some promote health of refugees and migrants through international cooperation, that is between country of origin and transit and destination. So this is an understanding between the country where they start and from through which country they are passing and through the destination. So most of the countries, prime minister or the minister of external affairs, they will be giving a statement that we are accepting the refugees, so you can come to us safely. So this is a statement we come across in the international news. So these countries receive the peoples, and the transit countries, they may not restrict them safely. They can pass. They give some of the limitations. With that limitation, they can pass those country, and a particular time they may announce. So sometime it happens to Israel. So they give time to refugees to cross the borders, and they open those gates. So these all are the international scenario, and national health system and ensuring the continuity of the care. So these are and governments called on the governments to develop policies and partnership that make refugee health part of universal health coverage. So here we have a comprehensive mental health action plan by WHO. So WHO global framework to strengthen mental health worldwide states that strengthening the governance, integrated the community care, and promotion and prevention, that is reduce the risk of trauma, stigma, and poverty, and information and research, gather refugees specific mental health data. So the targets by 2030 achieve 50% increase in coverage of essential mental health services, including for vulnerable groups such as refugees. So now we'll see about the mental health therapies for refugees and displaced communities. So this is one of the interesting part as a mental health nurse I proud to present here. So here we can see it's all the therapy you come across the textbooks, but here it works in a different way. It plays in a different way. So as the presenter said that when she read my profile, she spoke about handling the psychological emergencies. So proud to say that I came across a course from John Hopkins through online, that psychological first aid. It was the wonderful course which has given me an insight about this. How to handle these refugees and during the disaster. So this was the wonderful course I came across. So here the main thing is it focuses on cognitive behavioral therapy. So cognitive behavioral therapy is a one-stop solution, I say sometimes, because most of the time we have a problem, even in normal people's or abnormal people's or something with disaster or something with non-disaster. Our thinking is I used to say that it's quote by myself always that our thoughts are our strength and our thoughts are our enemy. So both friend and enemies are thoughts. So this cognitive behavioral therapy is always focused on thoughts. So these negative thoughts plays a major role in deciding the anxiety and how we respond to the anxiety, how we respond to the stress. So that's how we approach the thoughts. So these negative thoughts, it's very common and it's inevitable for the people who are refugees and who are internally displayed. So it's very difficult. Obviously, their thoughts, we cannot expect a single positive thoughts from those. The person who lost his mother, the person who has lost his father and his family or lovable wife or kids. And by looking at in front of their eyes, they may lose their neighbors, friends, and they may witness the crucial river of blood. So how can we expect that people to be having a positive thoughts? It's always a negative thoughts. So here the cognitive behavioral therapy plays a major role of altering the distorted thoughts and to building a coping skill. It is not a magic, it is not a miracle, it won't happen in a day. It may take time. So there is a saying that the time has power of healing. So it's not a one day. So obviously I have to recall here the process of grief, DABDA. It's a common thing we read from the day one from our nursing foundation. So depression, denial, anger, bargaining, and acceptance. So it takes a time. So this DABDA plays a major role. So here we have to give a time for the person to allow the grief and to cross the grief stages and to accept the things. So here the cognitive behavior therapy plays a major role in this by help of many thoughts. So you have a cognitive therapy, many techniques. So you have to craft the technique according to that and you have to administer to the peoples. So it's not easy because we have less manpower in the world. So we cannot go one to one and give the therapies. So we have different approaches and the cognitive therapy has to be crafted according to the need of the refugees and the place and the time and the situation. So next I talk about the narrative exposure therapy. It is a special form of CBT for refugees who experienced multiple traumatic event. So obviously the refugees may not have a single traumatic event, they have multiple traumatic event. So this helps the patient to reconstruct life stories, reframe traumatic memories, successfully used with SOT. So these narrative exposure therapy, we have a lot of evidence. If you go to the PubMed and if you come across, you can see the evidence of use these therapy for Sudanese, Congolese, and Syrian refugees. So you take your time to just have a read over it. Next, we talk about so this narrative exposure therapy. They will be narrating the events and they will be desensitizing the every thoughts related to the bad thoughts and negative thoughts. Next, we talk about the eye movement desensitization and reprocessing, that is EMDR. So used for PTSD. This is especially used for post-traumatic stress disorder. So here the helps the process traumatic memories by combining exposure with a guided eye movement adapted for use in refuge camp with Syrian war survivors. So these all are the simple techniques which can be given as a group. So this will help the group of people to come out from this therapy. Sorry, come out from the trauma. So next is group psychotherapy. That is to reduce the isolation stigma and family therapy. So integrational trauma if the families comes as a refugees. And next, as we all know, pharmacological interventions like antidepressant, antipsychotics, mood stabilizers, and can be administered to the traumatic peoples. So based on the signs and symptoms. So next, the main thing is focus on community and social therapies, so social support therapies. So psychological first aid, it stands first. So immediate support after trauma or crisis. Focus on safety, calmness, practical health, hope, and connectedness. So delivered by the trained community volunteers. So here the psychological first aid is many of the universities has the program in online. They provide for free. So here you, as a nurses and emerging healthcare professional or mental health specialized nurses, you can take over the module and you can practice yourself and you can train yourself as a psychological first aid provider. So you can volunteer in the many of the disaster and you can support the nation and community. Next, we have the peer support programs. Refugees trained as a community counselor or lay therapist build trust, cultural relevance, and sustainability. So the peer support program. So I can give an example during the COVID disaster. The guidelines of Indian government and enhanced has provided a trainer of trainer program. So this helps the nurses and healthcare professional nurse educators to train themselves for giving psychological support to the nurses who work in the COVID hospitals. And we have a in Institute of Mental Health Chennai, they have a 24 hours counseling center for nurses for this COVID crisis. So these all are the peer support programs. And next we talk about the faith and spiritual support. So working with religious leader to provide culturally accepted counseling, integrate the mental health into spiritual and cultural framework. Next is school-based intervention for the children. So usually this refugees has the access to school. In those schools, it is easy to reach those children and can do some manipulation over the children and to bring out them from the mental health crisis. Next is social and livelihood programs, cash transfer, job training, community engagement, and reducing the stress and improve the mental health by addressing social determinants. So next we talk about the innovative low resource therapies. So designed for humanitarian settings where specialist service are scarce. So here we have a WHO Self-Help Plus, HH Plus, group-based audio guided stress management course. So these all are the very beautiful courses and you will really get a good insight how to deal with how to become an effective mental health provider. and task shifting. So that is training the general health worker to manage common mental health condition, and tele mental health. So hotline and online therapy, mobile apps for remote support, and expressive therapy, art, music, and drama. So this helps the children to bring out from the crisis and trauma. So finally, I just want to give an insight about the research which has a wide gap in this particular specialized area, that is refuse and displaced communities and mental health nursing. So here you have, I have chosen two journals, and we have many journals in PubMed. So here, UHRC et al. 2005, Psychological Intervention for Refugees with Depression, a systematic review. So here, a systematic review, we have 20 studies. So culturally adopted CBT, which has brought out the patients. So you have most of the evidence in this. And next is Velu Yemi et al. Effectiveness of trauma-focused treatment for refugees youth. So these all are the proven journals. It's an European Journal of Psychotraumatology. So once you come across all these reading points, you will get an idea, you will get a knowledge, and you will get an insight how to handle the peoples. So this is what the insights short talk about refugees, displaced community in the perspective of mental health. So the take-home message here, I want to say that as emerging medical professionals or health professionals or nurses or whomever it's, mental health is not only confined to the person who is specialized in mental health or psychiatry. It's for everyone. It is our responsibility from the home, from our family to even the crisis place. Mental health is very, very essential. So, interestingly, I got on much insight while preparing this lecture today. So, there is a lot of research gap here, research opportunities, and a lot of projects are left over for these refugees and displaced communities. So, I wish everyone to have a great, everyone to have a look over it and grab the opportunities what all the available and can contribute to the community. Here the take home message: high mental health risks are there for the refugees and the displaced communities. Depression, anxiety, and PTSD, suicide and psychosis are the common problems, and there are many policies. So here, as a health professionals, what is our responsibility? And we have to update our knowledge and have to train ourselves in dealing with all these mental health conditions, and to be best citizens and to be loyal to our professions. So with this, I end the today's short talk for mental health World Mental Health Day. So I wish you once again all, and I thank for the opportunity. I thank the organizing members of Nursing Health Lab and to be having success in the future. Thank you.
Thank you, sir, for the extensive session on mental health during catastrophic events. It was definitely an eye opener towards the forgotten groups in our community and especially towards mental health. So we will move on to the next speaker. I now take the opportunity to welcome our second speaker for this evening, Mrs. Hindumati B. Mrs. Hindumati B is an associate professor, Narayana Hridyalaya, College of Nursing, Bangalore. Ma'am has completed her BSc Nursing in Coimbatore and her MSc Nursing from Narayana Hridyalaya, Bangalore, and has secured first rank for the same. With over 22 years of experience in the field, ma'am has excellent skills in teaching, worked as a guide and invigilator for various nursing colleges, as well as published work in the Indian Journal of Continuing Nursing Education and Journal of Nursing Science and Practice. We welcome you, ma'am. Over to you.
Thank you, Ms. Tanya, and good evening, everyone. At first, I wish you all a happy Mental Health Day. So my topic which was given was building resilient mental health system in crisis zone. So this is very important topic because we know lots of crises are occurring all over the global, and we need to be resilient for this purpose. So building a resilient health system so is very important. Based on that objectives, what I made is crisis and its characteristics, prevalence of mental health crisis, meaning of resilience and psychological resilience, building resilient mental health system, pyramid for intervention of mental health psychosocial support and strategies, and principles of psychosocial management, challenges and considerations. These are all things which we're going to see. So on the first chart, what is meant by crisis? A crisis is nothing but a situation where the individual is experiencing severe psychological distress, such as intense anxiety, depression, emotional suffering, to a point where they are not able to live their normal life, and the daily living becomes extremely difficult. So, in that cases, we call that as a crisis. This characteristics of crisis includes difficulty sleeping, difficulty in eating, inability to maintain hygiene, suicidal thoughts, and self-harming behaviors. So when we look at in any crisis affected area, almost all the people by whoever is experiencing emergencies will have psychosocial stresses. As Sir said, we have anxiety, sadness, hopelessness, aches, anger, irritability, fatigue, and sleep issues. So these are almost present in all the people. And when we look at the prevalence of mental health crisis, it is estimated that in the crisis affected population, 22% people experience depression, anxiety, post traumatic stress disorder, bipolar disorders, and schizophrenia. And 13% of the conflict affected populations will have depression, anxiety, and post traumatic stress disorder. And around 9% is estimated to have moderate or severe mental disorder. So when we looking at the crisis, already because of social problems and mental health problems, we are experiencing mental health crisis. And also in countries like India, where mental health services are limited, again the mental health services causes the issues. So already we have pre-existing mental health crisis, emergency because of the crisis emergency, it causes emergency induced, and how we respond to the crisis, that is a humanitarian response induced mental health crisis occurs. So now look at the social problems. So pre-existing problems are poverty, discrimination, and emergency-induced are family separation. So when the emergency occurs, when they are separated from the family, as Sir said, lack of safety, loss of livelihood, disrupted social network, low trust, and reduced resources. And to meet that humanitarian response, induced crises are overcrowding, lack of privacy, undermining the community support. And same when we look at mental health problems, which is already existing, depression, schizophrenia, harmful substance use is there. And in emergency induced, we can see grief, acute stress reactions will occur. So as Sir said, when an emergency occurs, it may be a crisis, it may be a conflict among, or it may be a war, anything which will cause us grief, acute stress reaction, harmful use of substances, depression, anxiety, and post-traumatic stress disorder. And the response created induced mental health problems are anxiety from lack of information about how to get the food or access to the basic services. And mental services issues are already there is a limited access to the quality, affordability of the mental health care. And because of emergency, it causes damage to the facilities, shortage of staffs, and disrupted medical supplies chains or surges in the demand, and which is overwhelming the present existing infrastructure. Humanitarian response, it becomes when we are giving emergency care, lack of coordination and insufficient training for the emergency responders. So these are all the crises which is occurring during a emergency or in a crisis period, and especially related to mental health. So how to deal with this? We have to develop a resilience for this. So what is meant by resilience? Resilience is the ability to adapt successfully to an adversity, stress, or a difficult life situation. And it is an ability to bounce back mentally, emotionally, and sometimes physically from the challenges or the crisis. When we have speaking about psychological resilience, it is the mental and emotional capacity to cope with the crisis. It is the ability for us to return back to the healthy states quickly after disruption. Here, it is influenced by the person's self regulation, optimism, how the external support which he gives. Then, resilience is an adaptive process, and it is not a merely an absence of mental illness. When we look resilience, the elements inside the resilience are self-efficacies and hardiness, the ability to tolerate or overcome the emotional distress, a positive acceptance of change, a perception of control and agency, spirituality, and positive coping skills. So these things we will be going in detail. So when we speak resilience, all the public have a myth saying that psychological resilience is a fixed, we cannot change it, and it is like personality or a trait like quality. But actually, the fact is that psychological resilience is malleable. We can refine it, we can make it shine. So we can make it shine in a place where it can achieve higher rates, and the person becomes increased self-efficacies and self-agencies. And how it refines, it is based on self-determination theory. It says when you have resilience training, it improves your therapeutic outcome and it facilitates long-term success in your adaptation. Coming to building a resilient mental health system. So if we want to have a proper mental health system, which is very resilient, it should be community based, culturally sensitive, and accessible. Mental health services should be provided to the community. The focus of building a resilient system is early identification, psychosocial support, and continuity of care amidst emergency. So the psychosocial support is a main aspect or the core aspect of providing mental health resilient system. And what is that mental health psychosocial support? That is nothing but any support, intervention, or a care that is aimed to protect or promote psychosocial well-being, prevent mental health disorders, and treat them when they occur. Or we can just simply say that, according to the International Committee of Red Cross and Interagency Standing Committee, the activities that address the psychological, social, and emotional need of the individual and the communities, particularly in the time of crisis, conflict, or disaster, is called as mental health psychosocial support. This mental health support is a major crucial for building the resilience in dealing with the crisis people or in case of stress or adversary. So this interagency standing committee, they have given a pyramid of interventions, as already sir has mentioned, providing basic services, security, community and family support, non-specialized services and specialized services. Provide basic services means it's just like a Maslow's hierarchy. So we have to provide the safety needs, the basic needs first, and then we have to give a humanitarian practices. Community support is we have to mobilize all the support, social support network, and provide safe environment. And non-specialized services is to meet these people's need based on their selected what is their emotional problems and practical support to be provided. And specialized, then next goes the specialized services. Here it says we have to give the primary healthcare support by the trained staff or by the mental health professional. The higher degree of the care should be provided. This is the pyramid which is given by interagency standing committee. Next, the WHO says what are the core strategies for building the mental health resilient system. So here the WHO says that where the mental health support systems services are limited, and we have to meet the people, as sir has indicated, the prevalence rate of refugees and the conflict affected areas. So we have to integrate the mental health into primary health care. The integration is a main core strategies for promoting a resilient mental health system in the global level. So we have to use evidence-based protocol, that is, they have found what is a mental health gap, humanitarian priority of mental health conditions. And we have to teach this. Hello. So we have to teach the staffs, and we have to make them screen the mental health challenges. So during their health routine health checkups, these people should be trained how to assess the mental health problems among the people. Next strategy is empowering the communities and families. So this is a recommendation which is given by WHO. So here they're saying we have to give a community-based initiatives, that is training the local leaders and community leaders to deliver the psychoeducation or psychosocial support. And we can also have programs like solidarity groups, which can be with the help of conflict affected women. They can establish their own networks and generate their own income. So in NIMHANS, what I have seen when we went for our postings, we have found NIMHANS as having some community outreach program. So they have conducted NIMHANS Center of Wellbeing and Community Connect in the initiative. That is, they do the conversation and give the psychiatric health educations in the public parks, and they have mental health Sante. So that is anti-stigma campaigning. So to promote the mental health among the public, we should reduce the stigma. Stigma is one of the blocking factor in addressing to the resilience. So the mental health Sante is organized, and rural community health programs are also being done. So then support caregivers is next one. So we including in the community. So program. So here the interventions is mainly for the caregivers. It may be parents or other caregivers. We have to look into their stress, their coping ability, and we should bring the positive parenting technique among them. So this will help the people who are having mental issues to become all right, and even to have a proper development of the children. Next is prioritizing children and youth. In any areas, the vulnerable groups has to be concentrated first. So we have to create a safe space for this vulnerable group. So how to create a safe space? So especially for child-friendly safe spaces should be there. So which gives a structured recreational educational life skill activities which will process them to come out from the trauma and build the social connections. And especially the children's, they should be having a trauma informed schoolings where they have to train the teachers and school counselors to create emotionally safe classrooms and provide psychosocial support, school based intervention that can reduce from post traumatic stress disorder and stress. So when we go to the community in psychiatric area, we have Sakalwara community mental health centers. There we have literally went to the school health, and we also have given training. So Gnimans does a lot of work to promote the mental health and build a resilient health system in India. And where the people we are not able to reach, physical access is limited, digital solution can be extended to reach the mental health support, to reach the mental health support. Here, remote services and social networks, as Sir said, we can use these things to address their needs when physical access is not possible. So we have telemedicine centers in Sakalwara in rehabilitations. We have seen that telemedicine people have literally working hard to connect with the people where they are not able to access. And they also not only provide psychological support, but they also give rehabilitation training. So like tailoring session and other sessions, they can keep them engaged. So the harshness technology really works in improving the and sustaining the care of maintaining a resilient health system. And not only that, WHO recommends address the social and economical determinants. So the mental health is influenced by the social and economical factors also. So it is undermined when the poverty, displacement, and food insecurity is present. So we have to provide a livelihood support, which is to be coordinated with the economic and social programs to address the job losses, financial stress, and housing instability. And as I said, you said, reducing stigma is a major thing where it can help in solving the social and economical determinants. Now we are coming to the detail how to provide a psychosocial support. So the WHO recommends we have to provide psychosocial support. So this psychosocial support is also an intervention guideline which is given by Mental Health Gap Humanitarian. Here they speak about certain principles of communication, assessment, management, reducing stress and strategy, social support, strengthening social support, protection of human rights, and attention to overall well-being. So coming to principles of communication. So basically, it is speaking about when you find a people who are having mental health crisis. So you have to openly communicate with them, build a rapport, and listen. So we have to listen to the inner and the external features. So you have to make them, you offer yourself, just talk to them and say them, may I help you? I will listen to you. Yes, it is difficult for you. So these type of words will help them really to start a communication with you. So that their behavior pattern, the nonverbal and the verbal communication, if you listen to them and give your time and say, as a psychosocial helper or a psychological foster, I'm here to help you. So that creates or brings up the principles of communication. So you have to create a positive environment for facilitating the communication, involve the person as much as possible, listen to them, be clear and concise when you're talking, be sensitive, and don't judge the people, and if needed, use appropriate interpreters. It is recommended to talk to the people in their own language. If we don't know the language, we can use the interpreters. Next is principles of assessment. Here, the assessment is not a total psychiatric assessment. So you're in an emergency area, so you to do a triaging, we may note the principles of assessment. So find out what are the complaints of the person, what is the family history, what is the general health history they are having, what is the coping strategies, whether they are using alcohol or drug, they are having a suicidal thought. Just as general physical examination can be conducted, and we can classify them whom we need to give more important care, whom we have to spend more time in giving psychosocial giving the psychosocial support, and who needs more resilience. So this is the principle of assessment, the second step they are saying, and principles of management. Coming to the third step, so managing, you have to plan the management. So the planning and management, you have to prioritize which management is important. Again, it follows Maslow's hierarchy. So you have to do the psychological needs, safety and security needs, loving and belongingness, self-esteem and self-actualization. So here you have to, as a psychosocial support worker, we have to look into basic physical needs and mental needs. So based on their level of priority, you have to make a proper plan of care and you have to refer them to the proper area and follow up. Next is principle of reducing stress and strengthening social support. So we can use all the stress management techniques and we have to improve the social strength. So here social workers will also play a lot of role. So we can have a connect with the social workers and the community people and we have to help them in doing the problem solving and we can use other interventions like how sir has said, CBT, behavioral therapy, anxiety reduction management, all these things can work out in this area. Next, while we giving all these interventions, we have to look into the principles of protection of human rights. So we have to keep the key stakeholders who can help us in protecting the human rights, and we have to protect the rights of the people. And we have, when you protect the rights of the people, it brings the integration of the people. So it will help in continuous improvement and optimize the wellness. Next is principles of attention to overall well-being. So we have to maintain this principle. We have to support the people to safely access the services which is necessary for their survival. And accessing these services should be in very dignified way. So example, we have to give them water, sanitation, food, shelter, livelihood, all the support should be provided in a dignified way. When we are not providing in dignified way, so people are not really accepting or community engagement is difficult to gain. So these are all the principles which is psychosocial support has to be taken care. Next, coming to challenges and consideration when we are doing a mental health resilience system, already the resources are less. So we have to, when we look at the national mental health budget system, we can see the physical health system that gets more budget, whereas the mental health system gets very less budget. So like this, resource scarcity will be a challenge for bringing out the mental health resilience system. And when a crisis occurs, the overwhelmed infrastructures occurs, and we have already fragile infra systems, which can lead to the challenge. And contextual challenges when there is a political instability or donor dependency and risk re-traumatization from the culturally inappropriate interventions in the area where we do emergency. If these type of instability is present, then there is a chance of contextual challenges and humanitarian response induced problems. So if the relief efforts are poorly designed, this will cause new psychological distress like family separation, overcrowding, and loss of dignity. So this also is a challenge to be taken into consideration. So now, looking into these challenges, we know how we can literally manage these challenges by overcoming this or pre-planning all these things. So thank you. At last, so we should be resilient. Thank you for your resilience. Patiently listen to me. Thank you one and all, and thank you to organizers.
Thank you, ma'am, for the elaborate session on building resilience in mental health care field at various levels. Without further ado, we'll move on to our next speaker and the next topic for this webinar. Our third speaker for this evening is Mrs. Anbeshwari. Ma'am is currently working as an NQAS Assistant Coordinator at Government Headquarters Hospital in Hosur, with 14 plus years of experience in nursing at various fields such as Operation Theatre, nursing institutions, and community health nursing, and brings a wide range of skill and enthusiasm. Ma'am has presented a paper in national conference conducted by Indian Society of Psychiatric Nursing India on March 2010 in Nellore, Andhra Pradesh, and various other publications in reputed journals like International Journal of Community Medicine and Public Health. We welcome you, ma'am. Thank you.
Thank you, Tanya. So once again, a very good evening to everyone here. So far, they have discussed the sessions regarding mental health strategies for refugees and also how to build this resilient system. Now we'll see how this community mental health system supports and how it has been decentralized and what are the benefits out of it when we decentralize this mental health system. So objectives we see here are mental health support, current challenges, what are there in mental health services, decentralizing mental health support, what are the benefits of decentralization, and community-based mental health interventions, and what are the models and approaches that are followed in mental health services, and what are all the current apps and AA system helps in decentralization of services. So mental health support system, it is an assistance and services that help people to maintain or improve their psychological and emotional well-being. So when we give care, which includes both the psychological and emotional well-being, only then we can get the better recovery from the patient. It includes not only the professional care and also the informal care, that is professional care from the psychiatrist, psychologist, counselors, psychiatric nurses, and the professional people, and this informal support from family, friends, peer groups, or community organizations. So goal of this mental health support system is to help the individuals to cope with the stress, manage mental health conditions, enhance resilience, and improve the quality of life. So this mental health support, it has a wide variety of services which includes crisis intervention that was discussed before, especially during the emergency situations, and providing psycho education to the needy people. It includes preventive activities, not only the service to therapeutic service, it also includes the preventive activities and providing social support networks to with different systems and giving medication treatments, and it includes a wide variety of therapies and also the counseling sessions. What are the current challenges when we decentralize this mental health service? Most mental health services, all we all know that they are available in the urban hospitals or in the city and towns and the tertiary care centers. There are a lack of area where this higher care is not possible. Like rural and remote areas, they face a shortage of mental health professionals, so they find it difficult to assess this care, and also high cost of specialized psychiatric consultations, hospitalization, and medication cost is also high, so they feel fear to get the psychiatric care. Out of pocket expenses that also prevent many families from seeking timely care. Since this mental ill people are of less productive, it is difficult for the family members to continuously provide this financial support to them, and many of the families, they start the treatment but they do not continuously follow up the treatment as of this expensive treatment medications. Stigma and cultural misconceptions is also a major challenge about mental illness that people are facing. Services designed without community input may clash with the cultural values. So whatever the services provided, it has to go hand in hand with the community support. Until otherwise there is support from the local system, it is very difficult, and especially this psychiatric treatment or this therapies, always it has a gap, and it creates a lot of challenges between the care providers and also the receivers in the community. Then decentralization of mental health support. So it is the major area where we have to focus nowadays, because this care has to reach each and everyone and in every part of the people. Decentralization here, it refers to shifting of mental health care from being concentrated in one area like specialized hospitals or institution based care to wide variety of community based services. So the psychiatric service should be available at the doorsteps. It means integrating mental health into primary health care, schools, workplaces, and local organizations, so that support is available very close to the people where they live and work. The main three aims or the main three areas where it focuses are accessibility of care to the undeserved and the rural population. So people those who are underprivileged and where the care is not accessible, there this decentralization theme will helps. And affordability of the care so that it reduces the cost barriers. Then acceptability from the community. It is the major important theme where this decentralization focusing. So accessibility, the care should be accessible to all the people. So the decentralization, it integrate basic mental health services into the primary health centers where community access is already available there. training community health workers, nurses, and general practitioners to screen, counsel, and refer the patients earlier. Mobile clinics and tele-mental health platforms also bridge the geographic barriers. So when we do this type of decentralization strategies, the impact would be it increases the early detection, prevents delay in care, and thereby reduces the treatment gaps. Affordability. So this affordability means the cost effectiveness. So it focuses on task sharing, that is sharing the major work not only from the psychiatrist, it has to train people from schools or nurses, that is community health nurses or the general nurses. They are given training to deliver the psychosocial support, lowering the dependence on specialized care. Community-based rehabilitation and support group thereby reduces the hospital readmission because they continuously get the follow-up care and there will not be any break in the treatment. Use of government-funded or NGO-supported programs at the grassroots. So when these strategies are followed, that is the integration of community and the hospitalized care and training of these people, automatically it reduces the hospital readmission. So the impact would be services become financially feasible for low income population and ensuring continuity of care. As I told you before, this continuity of care is a major uh, challenge what we face in mentally ill people. Then acceptability. So acceptability can be done through following these strategies. These community-led models ensure that interventions which align with the local beliefs and practices. It involves the most significant people from the community like teachers, religious leaders, community leaders, and peer mentors. So when we include all of these people in this community healthcare, which reduces the stigma automatically because they whatever they say the community people accept. So we have to capture all this significant people from the community, and it promotes help seeking in familiar, non-threatening environment such as school, workplaces, and local centers. So it should not be stigmatized as a part of day-to-day life activities. Like that, we have to make the people to accept that psychiatric illness, it is not an alien disease or anything. So it make when the significant people are speaking and they are talking about and they're creating awareness about this mental illness, the acceptability in the community would be increased. So impact would be it increased acceptance and uptake of services, especially for vulnerable groups like women, youth, and other vulnerable groups. So the benefits of decentralized mental health care includes it focuses on human rights, it reduces stigma and social exclusion, enhanced independence and dignity of the ill people, better integration of services, cost effectiveness, and increased innovations. Community health model, it will lay importance and it helps to identify support mental health needs. What all the needs are available. So with the significant people in the community, we can go for a survey and identify those are all the vulnerable people who really needs this mental health decentralized services. The most common problems that require the mental health interventions are like depression, anxiety disorders, substance use and addiction, stress and burnout, suicidal behavior and self-harm, domestic violence and gender biased violence, severe mental illness, example schizophrenia, bipolar disorder, stigma and social isolation. So these all problems are prevalent in one or the other way with us. So these are all the areas that need the decentralized care. It's not like every time we have to go and approach the psychiatrist in the specialist hospital. It is not like that. These services are nowadays available near our house itself. It has been done through different programs like WHO Mental Health Gap Program, that is Mental Health Gap Action Program. It provides based guidance to the people and it also trains them, increases the capacity building to the non-specialized health workers. It is very important here. It is not giving training again and again to the psychiatrist or counselors. It is choosing the people of non-specialized health worker in identifying and managing priority mental health conditions. So they are giving training to them to identify the earlier signs and symptoms of mental illness like depression, psychosis, neurosis, or epilepsy, substance abuse, etc. And it has been implemented in over 90 countries across the globe. Integration of mental health services into primary healthcare, it is a key concept here. Successfully, this program has been implemented in many countries like Ethiopia, Chile, and India. In India, district mental health program, it is a very effective program, and it has included or it has integrated this community health and also this secondary treatment area like district hospital, medical college hospitals, and it has included those higher centers with the primary health centers. It makes mental health care as a part of routine checkup, maternal and child health visit, and chronic disease management. So here this mental health program, it offers psychiatric OPD departments, counseling sessions. These OP departments are placed not at a separate area. As a part of this routine physical checkup, these OPDs are placed along with the other departments. So thereby reducing the stigma also. It leads to holistic care, reducing the divide between the physical and the mental health services. This district mental health program, it has a program called RBSK, that is Rashtriya Bal Sishu Karyakram. It is a very excellent program. It is a school mental health program which goes to the school, screen the children for physical illness and also the mental illness, and they identify if anything abnormality has been seen. Here they are teaching the signs and symptoms or the early identification to the school teacher, headmasters, and they also help to pick out the earlier symptoms. And from this RBSK team, the abnormally identified children or the adolescents are referred to DEIC, that is District Early Intervention Center. There, the children are assessed and interventions are given based on their need, and follow-up will be taken care by the block resource center. So this mental health program, starting in picking the children, giving treatment and follow-up. This BRC block resource center, this also follow up the children. So here again they are including the parent, school teachers, headmasters. So this community has a wide range of support to the people. The major models and approaches are National Mental Health Program. It is a flagship program to integrate mental health with general mental health services and focuses on community-based care instead of institutionalization care. It emphasizes decentralization and primary health care worker training. District Mental Health Program, it provides mental health services at the district level through PHCs and CHC. And task shifting, of course, we have seen it is the giving training to the general physician, nurses, and community health workers. Here, the general physicians also giving care to the psychiatric people, and if needed, they refer the cases to the higher centers. So they are given training to pick out or early identify the patients earlier, and referral also. Community mental health initiatives by NGOs, SCARF Association, it is a Schizophrenia Research Foundation, the Banyan, Ashagram, these are all the community mental health NGOs. They are also deeply involving to the community, and they are giving the holistic care and follow-up. Especially follow-up is very important here. Task sharing and lay health work models. It trains accredited social health activities, ASHAs, and Manas project. It is a successful program, has been done in Goa. So there they are sharing the work with the health workers. Integration of primary health system. So PHC doctors are trained to diagnose, manage common mental illness. Telepsychiatry and digital models. NIMHANS telepsychiatry project was launched in Karnataka. It was a successfully running program. And tele outreach for rural and remote areas. E-Sanjeevani and Telemanas was started in 2022 onwards, and they are giving the online services to the needy people. Community-based rehabilitation model. It focuses on social inclusion, livelihood support, and peer support groups. Example, Man Kaksha program in Maharashtra schools. So in Tamil Nadu, we have the district mental health programs. Of course, it has been implemented in all the states in India. School and youth based approaches. School mental health program, it includes awareness, early detection and counseling, youth helpline, and peer counseling initiatives in several states. I'll go to example here. Through this district mental health program, as when I was working in the casualty department, I received a child with the complaints of suicidal behavior. The age was only 14 years of age, and this was brought by the school teacher. So the school teacher was the history was like they were keep on observing the children for a week almost. So then they identified that something wrong with the child. They started scrutinizing the children. Then they talked with the parents and everyone. Then finally they came to the conclusion that it was literally a problem that as the parent have scolded to as the child has got less marks, the child thought of ending their life in the age of 14. See, until otherwise the school teacher has picked out, it would be a major disaster. So here the service of the school teachers, headmasters, it is all very important. And one more thing, this mental health program covers most of the government schools. Whereas the problem what we are faced is the schools which are all not allowing this group team people to enter, like sorry to say, in the private schools. So government schools, automatically the children are screened for physical illness and also for the mental illness because it is a part, and moreover every month they have to submit the report because they have a target to screen and do the complete surveillance among the school children. So as to reach the target, the doctors, general doctors, psychiatrists and nurses, they all go for the community nurses, they all go for the survey and they identify the mental retarded children, autistic child and everyone. But the problem, the challenge is the private schools, they are not allowing this mental health program team because this is all happening. So they feel that it is the school itself, they feel that if they are allowing this mental health team, it will stigmatize the school. So this pressure of education and study, this all will reflect when the child comes to 10th standard or 11th or 12th. Automatically the private school says they have to take the child back to some other school. So this is the mental pressure will be more for the parent and also for the children. Why I'm saying this is mental health program has to reach the private schools also because that is also needed, but it is lacking in India. That's what I believe. But there are some schools, they do the physical checkup, but I'm not sure how they are aware about this giving interventions to the mental illness. And this decentralization has been implemented in many corporate offices because it makes the service to be available in all areas. And nowadays there are many apps are available to support this decentralization of community services, thereby leveraging innovative features like AI driven personalization, teletherapy and community engagement. There are different apps available. This will help the people when they are feel stressed or when they feel solid loneliness. By the time they can log into this app, that app will guide you how to motivate their mind and everything, like Talkspace, Visa, Theravin, and Moodfit, Telemanas. There are different apps which we have to download and we can share our feel that will guide you how we have to change our mind and activities. So as a conclusion, this community-led and decentralized approaches are not just complementary, but it is essential for India's mental health system. By empowering these communities, integrating care into existing health structure and leveraging technology, mental health services can become more accessible, inclusive, culturally relevant, and sustainable. And ultimately, it reduces the stigma and improving the quality of life for millions of people, even among us. And for us also, these sort of services also may be needed in the near future. These are a few references. Thank you.
Thank you, ma'am.
Affected area.